This is Malika Hook from the University of Colorado, and I'll be discussing the topic of statins as they relate to the glaucoma patient, and specifically trying to answer the question, should you recommend statin therapy for your glaucoma patient? Past research has suggested that oral statin therapy may be beneficial to the retinal ganglion cell survival, at least in animal studies. Human clinical studies are also suggestive that statin therapy may decrease the incidence of glaucoma and potentially even slow down glaucomatous progression. The mechanism behind these potential benefits include controlling neuroinflammation, inhibiting ischemia-induced cortical changes, and enhancing retinal blood flow. Most of these studies are controversial, and there's no strong evidence-based medicine to any one of these mechanisms as it relates to glaucoma. Statins are also known as HMG-CoA reductase inhibitors. Statins act by competitively inhibiting HMG-CoA reductase, which is the rate-limiting enzyme in cholesterol synthesis. The different oral statins, which you see listed on the right-hand side, are typically used to lower blood cholesterol, specifically LDL, and reduce risk of illness related to atherosclerosis. So what are the data? I'm going to go over 4 different studies and try and impart what the level of knowledge is and what the level of evidence-based medicine is right now in the field of ophthalmology and specifically in glaucoma. One of the first papers that came to my attention concerning statin therapy in glaucoma patients was this one by Stein and colleagues. They set out to determine whether statins influence the development of open-angle glaucoma in patients equal to or greater than 60 years of age who also had hyperlipidemia. The relationship between statin use and the development of open-angle glaucoma from no prior open-angle glaucoma diagnosis was explored, as well as the progression from a prior diagnosis of glaucoma suspect to a diagnosis of open-angle glaucoma, and the need for medical or operative interventions for open-angle glaucoma. The hazard of developing open-angle glaucoma decreased by 0.3% for every additional month of statin consumption. And individuals with hyperlipidemia who took oral statins continuously for 2 years had an 8% decrease in open-angle glaucoma risk relative to those who received no oral statin therapy. The hazard of progressing from a diagnosis of glaucoma suspect to open-angle glaucoma decreased by 0.4% for every additional month of statin exposure, and individuals who took statins continuously for 2 years had a 9% decreased risk of progressing from glaucoma suspect to open-angle glaucoma relative to those who received no statin therapy. The requirement of medications to treat glaucoma was less for those on statins, but the need for surgery was no different. They did list several limitations, including the lack of clinical information, the lack of laboratory information, including cholesterol level. All of these patients were insured, so the applicability of this data to other patient populations might not be one-to-one. And this might be a more health-conscious population on statin therapy, and the information might not apply to those who are in different communities and maybe in areas where the health consciousness is not as great. The conclusion was that statin use was associated with a significant reduction in the risk of open-angle glaucoma, specifically among persons with hyperlipidemia. A second study of interest was by Kang and colleagues titled Association of Statin Use and High Serum Cholesterol Levels with Risk of Primary Open-Angle Glaucoma. They looked at participants greater than or equal to 40 years of age who were free of glaucoma. These were patients from the Nurses Health Study, the Nurses Health Study 2, and the Health Professionals Follow-Up Study. Incident cases of primary open-angle glaucoma were confirmed by medical record review. Among the over 100,000 participants, 887 incident cases of primary open-angle glaucoma were identified, and the findings indicated, number one, that 20 milligrams per deciliter increase in total serum cholesterol was not associated with risk of POAG. Any self-reported history of elevated cholesterol was not associated with risk of POAG. A history of any statin use was not associated with risk of POAG, and the use of statins for 5 or more years versus never using statins at all was not associated with risk of POAG. They concluded that given the inconsistencies in results among studies of statin therapy and glaucoma, more studies on hyperlipidemia, statin use, and the role in glaucoma are warranted. The purpose of this third study was to examine the association between oral statin therapy and the progression of open-angle glaucoma. Data from 847 veterans were reviewed to collect oral statin use history and to record demographic and comorbid medical conditions, as well as a review of their visual fields. Visual field progression was judged by an ophthalmologist who was masked to the statin use history. 31% of veterans had glaucomatous progression in at least one eye, with 49% not demonstrating progression. 20% were judged as being indeterminate. Approximately 74% of the subjects were on statin therapy. Progression rates were 35% for those who were using statins compared to 56% for those who were not using statins. This had a p-value of less than 0.001. They concluded that in this population of veterans, glaucoma patients with any history of statin use have lower visual field progression rates than statin non-users. This fourth study prospectively investigated whether simvastatin use is associated with visual field stabilization in patients with normal or low tension glaucoma. 256 eyes of 256 Chinese subjects with normal tension glaucoma and 36-month follow-up were included in the study, specifically looking for visual field progression. 31 of the 256 patients, or 12.1%, were taking simvastatin. 121 patients, or 47%, showed evidence of visual field progression during the follow-up. Logistic regression revealed that simvastatin use conferred a protective effect with a p-value equal to 0.03. They concluded that simvastatin use may be associated with visual field stabilization in patients with normal tension glaucoma, and a larger scale randomized controlled trial and cost-effectiveness analyses were warranted. The question remains, should we recommend statin therapy for our glaucoma patients? I think the figure on the right-hand side is one way to think about the cost-benefit analysis. Therapies that live in the green zone with high benefit and low risk are really a no-brainer for clinicians and patients to adopt. In the upper left-hand corner, where the benefit is low and the risk is high, the benefit of using the drug does not outweigh the risk in most patients. In the case of statin therapy, it is important to state that it is not without risk. Complications such as muscle fatigue and cramps may occur, increased liver enzymes due to liver damage, as well as the potential increased risk of diabetes. While the data are interesting, we lack evidence-based medicine to instruct patients on any benefit. I would summarize the answer to the question, should we recommend statin therapy for our glaucoma patients, in this way. Number one, we don't have evidence to recommend statin therapy to all of our patients. Number two, we can discuss the available data and inform the patients that we don't have level 1 evidence-based medicine to guide their therapy or even guide the potential risk factors from taking that therapy in their specific patient population. And number three, in low tension glaucoma, where a few therapies are available to halt disease progression, an informed conversation between the physician and the patient may lead to initiation of statin therapy independent of the presence of hyperlipidemia from a systemic standpoint, and close monitoring of that patient with their primary care physician would be warranted for the possible risk factors associated with statin therapy. I'd like to point out further educational resources, including KEOGT, which is a free glaucoma wiki available to anybody who visits the website. You can also visit the YouTube and Instagram channels below for further videos and educational material. Thank you.